really pleased to introduce the first speaker of the next session, my interventional radiology colleague, Dr. Raghuram Laxminarayan. Raghu has been a consultant vascular intervention radiologist at Hull University Teaching Hospital, NHS Trust, for the last 16 years, having moved to this post from a consultant position at the Royal Brisbane Hospital, Australia. He has been the head of training for the East Yorkshire Training Scheme, Deputy Training Program Director, IR for Yorkshire, and has served as an expert advisor to NICE and the British Standard Institute. He has also been a member of the National Thrombectomy Implementation Group and member of the Credential Group for Stroke Mechanical Thrombectomy of the Royal College of Radiologists. He has been a member of British Society of Interventional Radiology Scientific Program Committee for 5 years and is the Regional Secretary there. His research interests include aortic, peripheral, vascular, stroke and embolization techniques. He has published extensively and has been an invited speaker at national and international congress.
Thank you
so today he is going to give us an update on role of interventional radiology in obstetrics. Thank you, Raghu.
Thank you, Anju. That was very I should apologize. I'm feeling a bit under the weather. I know I'm in good hands. I can give you my past history if you want. But I was also not sure that so many of my colleagues will be here. So forgive me if I'm saying something that you didn't see on the shop floor. Oh, the mic's not working. Do you want me to show you? Will that work? Can you hear me? Can you hear me? Yeah, perfect. First pitch, Society of Anesthetic Radiologists. They are an affiliate member of the British Society of Interventional Radiology. The thing is sarweb.co.uk. Please have a look. We would welcome you to be part of an affiliate member of the British Society of Interventional Radiology. The next thing that I wanted to say was, if you can use your mobile phones, that would be great. The question is embolization similar to arterial ligation? If you can't get the QR code, if you just go to slido.com and use 3706317 hashtag, you will be able to get to this. Do you think embolization is similar to arterial ligation? You know, what I call embolization as an internal tie. Instead of somebody tying the artery from outside, we're trying to tie the artery from inside, and that is the question. So the answer is overwhelming no, which I think is right, and I'll try and tell you why it is. The next thing that I want you to do is you can type an answer for this. It's at the same Slido code. If you want to just type an answer, what comes to your mind when you think of a postpartum hemorrhage? What do you think, or what? To my mind, it kind of brings fear. That's what it brings. But it'd be nice to know if you people have any thoughts on it. Blood, yeah, of course. We need a lot of blood products. 4 T's. I will be talking about 4 T's. Blood pressure, emergency. That's very nice. So most of you say 4 T's, and I have included the 4 T's in my talk to see where we might be able to come with interventional radiology. Tranexamic acid is the great thing that every one of us can use. So thank you for that. That's a lot of information there. Okay, so whatever is in bold and big is something that everybody, lots of people talk about. Okay, moving ahead. I don't know, there's lots of people in Hull Royal Infirmary. What you know in Hull Royal Infirmary is that bit is your maternity wing, and I call that an umbilical cord that connects the maternity wing into the second floor where interventional radiology is present. It was the autumn of one of the days. What happened was there was a 32-year-old lady who kind of plapped out, literally. There were a couple of phone calls back and forth saying, can we bring her in, can we bring her in? She is bleeding, we are not able to control, we're not able to maintain blood pressure. okay? And what I did was, this is a simulation of me pulling a trolley, trying to go through that umbilical cord, trying to take the trolley. Just imagine, this thing does not have anything connected to it. Obviously, you will have your pumps, you will have your infusions, and you will have a patient on top of it. So what happens is, for those of you who know, Hull Royal Infirmary, know that you come through this particular part, and most often, that particular evening when I was doing it, it was quite clear. Otherwise, you can see, you get all these kind of obstructions. You have to maneuver yourself through these obstructions, take a turn, go through a set of doors, and then you get into humanity, because there are a couple of lifts there. There are people walking in and out of those lifts. You have to go through a very busy corridor of taking patients through. So this was taking me about 1 minute and 30 seconds. You can see that people are coming through the lift. I'm actually running with, pulling that trolley behind me. So you will have, this particular lady came to interventional radiology one autumn morning, and by the time we could get to her artery, the artery was completely clamped up. We just couldn't get to her. So those of you who know, you come in, you go through this second set of lifts, and then you take a turn there, and IR is somewhere in that corridor. So that is a dreadful situation to be in with a patient who is bleeding. Can you guess the conclusion of the talk? Because 40 minutes is a long time. I don't know what we can do in 40 minutes. So I'd like you to type out what you think are going to be the conclusion of my talk. And then we can go through the talk and try and figure out. Because most people trying to have attention within time is very difficult. So prepare, plan, hybrid theatre, that's excellent. We have to expand on what you mean by prepare and plan. Because what I'm trying to say, or what I'm trying to do, is to tell you as to when time critical, plan early, we need combined theatres, don't get pregnant. Yes, that's a good solution too. Right. What is embolization? This guy in circa 1864, this Russian guy, I think saying Russian in this country is a bit of a bad word, but there you go. This Russian professor said an era of new surgery would become if you're able to stop the flow in a major artery without exploration or external compression. And he was talking about interventional radiology. That was 1864. The beautiful thing about it is it was 1964 when it's the birth of interventional radiology, when people started getting into arteries and stuff like that. So what I was saying was ligation or internal ties. So the one thing that we can do is, instead of ligating an artery from the outside, that is somebody wading through a lot of blood, what you can do is you can go inside an artery and put an internal tie into it. So that is one thing that we can definitely do. The second thing that we can do is float particles, like you would have seen this kind of thing happening with uterine artery embolization. Because there is flow, what you can do is you can float particles in that go more distal to the circulation. What do I mean by that? So if you look at this, what we have done is, what you can do is, if you take a catheter and put particles of various sizes, what they will do is they'll float themselves through the circulation, and you can decide, you can have pre-formed particles, let's say 300 microns, 500 microns, that will go to the capillary level or wherever and block that circulation. So one, you can block it where you want it to be. Second, you can float it down and block where you can. And third is we can do balloon occlusion. That is what we call an endoclamp. You can put a balloon in the aorta, you can put a balloon in any of the iliac arteries and clamp the arteries. That's called an endoclamp. So I'm going to not bore you, but take you very briefly with the technique. How do we do it? So what we do is we get into the femoral arteries on either side, and you've got into femoral arteries, you've got into radial arteries, very similar, needle, wire, then we put a sheath in, and we have catheters of various sizes. And generally, what we tend to do is, if you're going into the left artery, if you're going into the left internal artery, we tend to go over and above. That's because the U-turn is more difficult to make. So if you want one internal, if you want two internals, we come in from both sides. So 2 femoral artery punctures are what we do. The second thing is we have catheters that are very small in size that can go inside the bigger catheter and taking us distal into the uterine artery. So those are the 2 things that we tend to do. Once you get where you want to get, that's when you decide what kind of embolic agent. Like you can use a coil, you can talk of simple destruction or simple occlusion, exact sites to be occluded. We decide on what we need to occlude and then take it forward. I'll tell you the 4 scenarios what we do with postpartum bleed. Now the thing that's important is this particular circulation has extreme collateralization, especially with pregnancy. There's a huge amount of collateralization. So what happens and why, and this is important, why when your obstetrician says, I'm going to ligate the internal iliac, why it doesn't work is if you ligate the anterior internal iliac, it tends to flow through collaterals and come and fill the bed. So that's why ligation doesn't work in many points. What you need to do is to send something that will close the entire bed. The only way we can block this room conclusively is to put something that is solid in the room. Because if you close one door, somebody else may come from the other door, somebody may come from the window, somebody may come from somewhere else. So you need to float something in order to close that off. So what is the entity that we use? We use a gelatin sponge. That's what we do. Cheapest material. And the way we do it is this. So what we tend to do is we cut up gelatin sponge. It comes in a big block. So you just cut bits out of it and then put those bits in one of the syringes. And then once we put them in a syringes, we need to see where it is going. So you need some contrast. So what will happen is it will put it in a syringe and then mix it with contrast and saline, 50% contrast, 50% saline, and then we agitate the 2. When you agitate the 2, what happens is you get a foam kind of substance, a gelatin foam. And you can inject that foam into any catheter. In fact, if you have a catheter in the wrong place, as long as you don't inject it into an artery or vein, supposing somebody got a liver puncture or something like that, if you're taking it out, you can put a gelatin plug in it. It will generally swell, and then once it gets swollen, then you can inject it. So what my colleague has done is she has put that gelatin sponge into a small syringe, and then you can inject that syringe in. So gelphone is a temporary occlusion. This is one of our obstetricians. Her job is to cut up the gel foam and start agitating them. Temporary occlusion for 3 to 6 weeks. You can embolize in various sizes. Okay. So vascular trauma, organ salvage and bleeding control is the key thing with vascular trauma. And if you want one take-home slide, this is the take-home slide from my point of view. So you know that the obstetricians are doing something here. You know that you guys are doing something here, trying to reduce the bleeding. Unfortunately for us, uterine artery embolization, I think, is thought about too late. And that's thought about too late for a reason, because I showed you the IR department is somewhere else. You know, the whole concept of trying to shift this patient is a problem. What it should do, and what y'all can do, is start talking about it a bit more early, saying, hey, do you think we need to call the IRT? Do you think we need to consider embolization? And I think, you know, bringing that up into a much faster thought process. You all said, you know, prepare, plan, and stuff like that. That's exactly the point. You gave the conclusion of the talk. So try and think of UFE much before. And everyone said the 4 T's. So where are the 4 T's in which IR can be a major factor? So trauma, if there is a traumatic pseudoaneurysm in a particular area, unless that vessel is clipped off, it's going to continue to bleed. So wherever there is trauma and wherever there is placental retention or tissue, IR is going to make a difference. So remember, of the 4 things, it is those 2 things that where IR is going to make a major difference to you. So let's go through 4 scenarios. What is it that we do when you get to the root? Scenario 1 is what we do is we do an angiogram and we see this diffuse blush. That's just arteries going into the uterus. So what we tend to do at that point is pre-embolization. You can see the catheter producing the blush. What we have done here is injected the gel form slurry, and what it has done is it's made this devoid. There was a lot of circulation there, it's devoid of circulation here. So when you see a diffuse blush, you don't know where the bleeding is coming from. You're injecting gel form like a slurry that goes into this vascular bed and closes it off. So pre-embolization, you have vessels going into the pelvis. Post-embolization, you can see that the pelvis is devoid of vessels. That's one scenario. The second scenario is a pseudoaneurysm. This is where all pseudoaneurysms are traumatic. Okay? And when I say trauma, it's the blade of the surgeon. Let's cut it somewhere. So you can see here that there is a blush coming up. This is a pseudoaneurysm. So when we have a pseudoaneurysm, what you can do is put a catheter specifically into that, and then we can use coils, or you can use a plug or something like that to plug just that particular artery off. So you don't have to make the whole area devoid of circulation. The third one is the more dangerous one. You can see that this is more distal, somewhere at the cervix. When you inject contrast, the contrast is just extravasating out, the contrast is flowing out. So that's the third scenario, where what you tend to do is we go into that specific vessel. You can see the amount of contrast flowing out. You go into that specific vessel and block it off with a coil. So like a pseudoaneurysm, you can go into that specific vessel and just take that specific vessel. Then you may have trauma. The fourth scenario is trauma to one of the pelvic vessels like I showed. Once again, you can see here that what we've done is put some coils in to block that off. So those are the 4 scenarios. How good is it? They say about 70 to 100%. Rebleed rates are around 5 to 10%. What does that tell us? That tells us that we need to have the patient somewhere nearby. If the patient rebleeds, we can take them back into the theatre to check, do a check angio. What does the Royal College say? The Royal College says, much better, 85% of the situation does not impair subsequent menstruation, fertility, and obstetric outcomes. We'll come to that a little bit at the very end. What are the predictors of failure? The predictors of failure are bad timing. That's the case with everything, isn't it? So bad timing is a predictor of failure. The second predictor of failure from our side is if there is DIC. What happens is if we are trying to induce, most of these embolic materials are making use of the fact that there will be some clotting happening. If there's no clotting happening, then it becomes a huge problem for us. Repeat embolization is a key thing that somebody has to keep in mind. If it's not worked, we can embolize again. And embolization after surgery or hysterectomy is far more difficult than before, because the arteries would have been tied off and we need to go through arteries that have been closed off. I'll briefly deal with abnormal placentation. This is another thing where we made a little bit of dent into. So planning and timing is key. Some of you said hybrid theatre. That's exactly what we did. Use our hybrid theatre for delivery and hysterectomy if required. So a huge number of people involved in the whole group and a lot of MDTs prior to the procedure. This is what we used to do. Come together about a week before, talk about it, and come on the day to do the procedure. There's a lot of talk, do you want to smile? All that goes above my head. But I'll tell you what is it that we've been following, and that has been successful, and that is this. So what we do is step 1, under local anesthesia, we get into the femoral arteries and put 2 balloon catheters into both internal iliac arteries. So that's step 1. How long will we take? It's done through this. Usually takes only about 3 to 5 minutes with very little radiation. So baby's still in the womb. We used a catheter, we've gone across, and then we put some balloons on either side. So there's a balloon. The balloon is not inflated. It's put into both internal iliac arteries. So once that is done, step 2 is GA, followed by cord clamping. The baby comes out, the cord is clamped, and then we inflate the balloons. We don't need to, there's no radiation at that point, we just have inflators, they just inflate the balloon. So with adherent placenta, what then the obstetrician can do is, obviously you're giving medication to try and increase the uterine tone. What the obstetrician can do is try and deliver the placenta at that point in time. If the placenta is fully delivered, then fine. If it's not, what we tend to do, this is the balloon inflation, what we tend to do is check whether the placenta is coming out or it's still bleeding. One of the things, we tend to put our balloons in the internal iliac artery. One of the things that you should remember is some people place balloons in different areas. You can put a balloon in the aorta, you can put a balloon in the common iliac, you can put a balloon in the internal iliac, wherever you want. The only problem of putting a balloon in the aorta is it reduces drastic circulation to the legs and all that. We don't do it, we just do it at the internal iliac. So, coming back to it, what we do is if the placenta is not coming off and it's still adherent, then we tend to do an embolization. We try and embolize this area with gel film. And once that's the same pre-embolization, post-embolization picture, do it on both sides. Once that is done and it's devoid of circulation, there is a step to assess bleeding. If there is continued bleeding because there's placenta increta or something, or there is a decision to do a hysterectomy, then we do a massive embolization and render that entire thing quite significantly avascular so that the blood loss is less. So it's done in stages, trying to help the abnormal placentation come out. So we published this. This was published 2023 in JVIR. It's an interventional radiology journal out of US. So we looked at 16 of our patients. When you look at it, most of them had at least one C-section, previous DNCs, previous placenta accreta. So these are high-risk pregnancies. When this is happening, you should think of a situation where you have a hybrid theatre availability. So technical success was defined either by the ability to assist placental separation, uterine artery stasis, and absence of reintervention. So this is the key slide. So when you look at it, the blood loss was in the range of 500 to 5 liters with an average of about 1,900 mils for these patients. And we were uterine sparing, and this is the most important thing. In 60% plus of these patients, we were uterine sparing at the end of the procedure. Okay, so blood loss of greater than 3,000 mils were about 25% of the patients, right? So no fetal complications. It was generally done where there was no embolization or re-exploration because we did it in that staged manner, and then no access site complications. When I speak to my friends in St. George's, what they tend to do is they send the patient back with sheets in the femoral artery back to the unit just in case they need a repeat embolization. That can cause femoral artery complications. 2 patients required a day of stay in ICU. So once again, as you said in your conclusion, on an emergent basis. So what our study highlights is it should be a combined elective procedure and C-section to be done in an angiographic suite followed by prophylactic uterine artery embolization is probably far more safe than doing it in the obstetric theatre out there. 38. Do we have time to play this? Yes, let me just play this. This might be interesting for you to listen to.
So I understand from George because he was breach, and they said that this is probably why it's happened within day because of my scar from where George was removed. My placenta is attached to my old scar.
A couple of years back, this shifting patients back and forth was not a great idea. We got a hybrid theatre suite. So I contacted Uma and said, would you all take on the aspect of coming over here and delivering the baby here so that we can do everything in one safe environment?
My consultant explained it to us, didn't she? Like, she said it would be very overwhelming for me.
Well,
and
well,
it was
that's
when we went into theatre. I didn't expect 12 individuals then, and we different team in bed.
So we had to do a lot of troubleshooting, we had to do a lot of fine tuning, and the way around that Raghu and I felt was having an MDT meeting, which was attended by midwives, theatre staff, by oncology, by neurologists, radiology staff, anaesthetists and obstetricians.
I really respected the fact that it took the time to explain things properly to me, because I think quite often I think dads can get left behind in situations like that.
We're very fortunate to have this level of expertise in home, to be able to do this on an elective basis.
I'm very happy that we have saved him and he's going back with the womb intact.
Let's stop that there. So, what are the concerns? Femoral artery complications, radiation to baby, radiation to mom, and in the embolization side effects. So, complications to the femoral artery in literature, even though we didn't have any, but we do consent patients for, is about 1 to 2% of hematoma, less than 1% where they can have a pseudoaneurysm or a retroperitoneal bleed. Thrombosis and dissection is also small. The way we have come out of it is we don't keep the femoral artery catheters for a very long time. We just take them out as soon as the procedure is over, so that we can repuncture if required. Fertility, there's been some studies, because the question that's asked is if you put in this gel foam slurry into the uterus and just bung up all the arteries, what happens to fertility? So far, all the anecdotal studies have shown that there isn't a huge risk of, the fertility is spared, but there's a higher risk of miscarriage and C-section requirement with synechial formation in situations where we've embolized significantly. Radiation, I don't think the radiation dose is very high. If you know the lifetime risk of cancer in the UK is 50%, because of all the radiation that's involved here, radiation of flying, radiation of everything else. So when you put that in context, the radiation risk is quite low. So I think we need an RCT. I've been contemplating about it and trying to ask somebody about it, but the problem is trying to get an RCT to say, yes, we will do postpartum hemorrhage and do the delivery in a hybrid theatre, or we will revert to the old means. And getting patients to randomize for it is asking for too much. So in conclusion, embolization is an effective method. Timing of procedure is the key to success, as you all said. Consider balloon occlusion and embolization in adherent and invasive placentas. What some units do and can be done is, even if you have two separate areas, you can get the balloons placed in radiology, take the patient to the labor room, because for inflating the balloons you don't need x-rays. We can inflate and deflate the balloons. There are complications to be aware of, and we need more evidence. So I'll leave you with, once again, this Slido thing. You can show of hands and ask me questions, or if you want to just type the question, you can go ahead and type it. There's somebody.
I was just going to ask, are there any cases you wouldn't do in your hybrid theatre? So we do these in Nottingham as well. Sure. And we find that the vast majority of accretor or accretor cases have some kind of bladder involvement that need urology input, for example. So are there any cases you wouldn't do?
So we had that very situation. So we had a urologist come and join us. So we have airflow in our hybrid theatre with a 1 minute or 2 minute circulation. So it's pretty much everything that's available. I think it's a mind shift change. The moment you say, urologist, you want to come in and operate in this particular environment, they're not very keen to. I think that's the thing. But convincing it's a human factor issue rather than actually doing it issue. Yes, that's the answer. We don't no longer have a placental listing, and that's because of funding. I think the funding is now gone to Sheffield. I don't know how they do it in Sheffield, if you have anybody from here. How do you confirm placement of balloon without the use of radiation? No, I didn't say that. So we place the balloon under radiation and then leave the balloon there. So the balloon's not going to move, and then you can just inflate the balloon. So to inflate the balloon, you don't need radiation. So what happens is we have a inflation device. If you take that inflation up to, say, 8 atmospheres or something on the inflation device, we know the balloon's inflated inside. So that's how we confirm it. Do you find GA easier than CSE in this setup? So what is CSE?
Combined spinal.
Oh, spinal. We have done 2 patients with spinal. It's usually an anesthetist thing. The thing is your 2 or 3 hour window that you have with the whole thing happening within that window period. What we have found is once we place the balloons in, most of you want to have a general anesthetic and get the baby out, and then you can relax and see how you're going to take it. One of the good things is if it's bleeding, you're in the right place.
I was just wondering, what do you suggest? What would be the best way to do it in an emergency?
So that's what I said. In an emergency, trying to consider embolization earlier is a good thing. That is because you are going to shift the patient. There is going to be a point beyond which you're going to say, look, I can't shift this patient. And unfortunately for us, people wait to that point, and then there is a huge debate. So trying to find patients who's had previous cesarean section, who may have placenta in the wrong place, etc., might be helpful in saying, look, this is a little bit of a dodgy situation. Do you think we need to shift the patient? Ideally, you should be in the same building.
So we've had, in York, the radiologist come to us with a C-arm. Is that, I realise that your situation isn't so ideal, but that can be better than moving the patients, or is it just by Hero who's...
No, C-arm is difficult because it has a very small camera.
Yes,
so
and I appreciate that.
So well. So I don't know whether your theatre tables are radiolucent. That's another.
Nor do I just know it's happened. I wasn't there.
Yeah, that is an option. That is an option. Yes, we have a 24/7 service for IR. Yes, we are 40 minutes away in the middle of the night from having the patient on the table. Yesterday morning I was at 6 o'clock in the morning for an aneurysm rupture. So we treat aneurysm ruptures in IR. So.
Christina Rogers from St Mary's in Manchester. Our issue is, yes, we've got quite a big interventional radiology service, but not with expertise in gynecological interventional. So certainly we do this and we do it in a hybrid theatre, which fortunately for us is just along the corridor from our obstetric unit, as in there are about 8 operating theatres, 5 of which are ours, and the rest are vascular. And so that's the elective cases, that's fine. But even then, we can only do them on certain days of the week because we only have the radiology expertise on a couple of days a week. Out of ours, we certainly, on the whole, don't have access to an interventional radiologist who would even contemplate on doing this.
That is a problem, especially with resource crunch. Would it correct to say training has to concentrate on decision making in addition to other elements? Absolutely. I think the decision making is the key, and that's where experience comes into play, I guess, to call at the right time in order to say, yes, we need this.
So you mentioned calling at the right time. For me, I think it's that balance between the point that you have substantial blood loss but you don't want to go into DIC. Is there any minutes at that point of placing a intra-arterial balloon catheter to stabilise to the point that you can then transfer to the hybrid theatre?
That's a good question.
Because thinking about the blood loss, if I'm losing 300 to 500 mils a minute, I'm not going to be transferring somebody that is then going to take, you looked at a minute and a half just in the corridor, that's going to be a 10-15 minute transfer. Absolutely. At minimum to get to an IR theatre. But is there anything we could do such as an intra-aortic balloon,
Yes.
to stabilise tube transfer?
Yes is the answer. So there is this balloon called the Reboa balloon. The trauma units in London use it. So you get into the femoral artery. The balloon comes with markers like any catheter markers. You put it up and blow it up in the aorta. They do it without radiation for trauma, and it is done on site of trauma in order to bring the patient in. It's called the Reboa. You can Google it. That balloon can be made available and used on the bedside. It's a bit of an expensive piece of kit. It's just a balloon on the end of the catheter, and they want some 2 or 3 grand for it, but it is available.
But is that something that actually should be considered in part of the protocol?
It should be considered, and people should push for it. I was speaking to a Brazilian obstetrician, and what they do is they use a balloon catheter in the aorta simply because it is cheap. It is cheap. In Brazil, what happens is all this gel foam and all this combined theatres and it's all these catheters are all reused and expensive. Whereas one balloon, so when they have bleeding, they get their interventional radiologist in and they just put a balloon in the aorta. It's like an endo clamp, and that gives them time to do whatever they want to do to mop up. So they do use it in Brazil and in third world countries where cost is an issue. I don't know with permission.
One more question.
One more.
Last question.
Sorry, mine's not actually a question, it was just a follow-up on the Reboa bit. I'm Bex, one of the ICU trainees, just to add, before everyone gets excited about Reboa, it's just been dismissed really, because the first UK RCT for Reboa in trauma in the UK stopped only because of armed patients, so increased mortality. So yeah, maybe don't get too excited about Reboa, because I don't think it's going to be
it's just a comment on it. It depends on who is doing it.
Yeah. Yeah. And in the UK,
I'm sure
it's
if you do an RCT with me intubated,
yeah. It's our